Very good. So I'm Professor Thompson, one of the consultants from ICU. I've met a few of you, but not everybody. So for the next hour, so we'll just talk about ethics and intensive care admission, which is what we all kind of do every day, and that we just may not have thought about what we do when we're doing it. So what I hope is that you will tell me all the answers to all the questions that I ask you. I'm going to try and make it as interactive as we can. So I hope you'll explain the 4 principles of medical ethics and be able to discuss how it's relevant to the critically ill. Also, some understanding of how decisions are made, some of which will be made at your level, but some, particularly for ICU, are made at consultant level or certainly deferred for a second opinion, and then apply these principles in practice. So that's it in a nutshell. So I'm going to start off with a few cases. These are all real cases, so there's 4 of them. And what I'd like you to do is have a look at this, and then we'll just have a show of hands whether you would or would not admit to intensive care. So the first one is a 63-year-old lady with AML who was diagnosed 2 years ago, but relapsed 8 months ago. She's got limited physical capacity. She's had 3 cycles of further chemo since her relapse. She then became neutropenic, got pneumonia on the oncology wards, and now has hypoxic respiratory failure. She'd also had some GCSF, so white. She's no longer neutropenic. She does have a white count. Frailty score is 3, and the EWS is 12. So the DART team have been coming to you all morning at 20-second intervals saying, will you admit, will you admit? So that's the information you've got. I'm not going to give you anything more at the moment. So who would admit this lady to ICU? So we've got 3 yeses, 4 of a yes, 5 yes. So we've got any, you're not allowed to don't know, because as consultants, when somebody says, should we admit, we're not allowed to say, oh, I don't know. So we've got, what did we say, 5 yeses and 4 no's. Oh, almost split decision. Exciting. Right, the next one is 90 years old. She's frail. She was self-isolating during the pandemic. She was frail beforehand, and she's got even more frail. She's got not a huge amount of past medical histories. So there's hypertension, which is standard for that age group. She's had a hip replacement, which is kind of standard. Osteoporosis, kind of standard for that age group. And she's now had an upper GI perforation, or is thought to have, and the surgeons are saying, should she have a laparotomy? Now, she has a frailty score of 8, which is pretty impressive. You can't get much higher than 8, but an EWS of only 2. Okay? Would we admit her to intensive care? Anybody say yes? So we've got an overwhelming majority of 9-0. This is like a Man United football score. Man United 0. Other team 9. Perfect. Okay, the next one is a 24-year-old lad who unfortunately has an osteosarcoma, has had surgery, so he's had an amputation, and then he's had chemoradiotherapy. He had a CT a month ago, and that showed lung, bone, and paraspinal metastases, and he's had some palliative chemoradiotherapy, but was admitted to ED with a collapse with SATs of about 50. Thought to have lost consciousness. His SATs have improved, but he's got an EWS of 9, and the clinical diagnosis is query COVID pneumonitis. Would you admit him to ICU? Nobody would? We've got 9-0 again. This is your brother. Doesn't affect things at all, obviously. Just sort of try and trick you. Okay, the next one. 48-year-old morbidly obese with asthma. She's also got a schizoaffective disorder and has been housebound for 3 months because of leg pain. She's got a frailty score of 5. Again, COVID pneumonitis is a provisional diagnosis, low saturations, early warning score of 7. So would we admit her? She's 60, she's morbidly obese. Anybody admit her for treatment? So Dinesh, calling the kite. Oh, look at these lemmings. Okay, so is this 8-1 or 9-0? We got going 9-0? Yeah. Aslan, would you admit this lady to ICU? You've got 5 seconds to digest the information. So possibly is not allowed because you can't say possibly. So it's just a yes?
Yes.
We've got a 10-0 majority. Okay, so we're going to come to what actually happened. These are all real life cases. We'll come at the end of the talk. Okay, who can tell me what are considered the 4 pillars of medical ethics? We can do one at once. Shout out.
Beneficence.
Beneficence, yeah.
Justice. Non-malevolent.
Non-malevolence. No, we don't. We do malevolence here all the time. Maleficence.
Maleficence.
Yeah. Yeah.
Justice.
Yeah. There's another word that goes before justice. But justice will do. Yeah. And autonomy. Yeah. That's right. So autonomy defines the respect of the individual to decide what they want for themselves. We must treat with humanity. Okay? Beneficence is the duty to do good, whatever that means. Non-maleficence, first do no harm. Yeah. And then, so if you put the word distributive justice, I think it clarifies it a little bit. So what that means is about treating all people equally and equitably, irrespective of any other considerations. Okay, so those are the things that you youngsters haven't signed the Hippocratic Oath like I did when I qualified under Hippocrates in 2000 BC. But those are the sort of things that they're in the GMC's code of conduct, so they're still there. Okay, who knows just a bit about the history of ICU? Anybody got any idea about it, where we came from?
It was a negative pressure that was used like mainly for the polio.
It was. So roughly when was that? Yeah, it's 1952. Yeah. So there's an interesting story that it's a chap called Ibsen, no relation to the playwright. He was an anaesthetist in Copenhagen in Denmark, and they had this dreadful polio endemic. Well, it was a pandemic actually, and there was no cure. People were dying of neuromuscular paralysis, and there was this physician called Bjorneboe, and they had a particular patient that was sort of dying in front of their eyes, and actually it was Ibsen, got a tracheostomy form and then paralysed the patient. So this is the first patient, paralysed them, and the patient survived for a little while. But they then had this idea about sort of manually giving an anaesthetic, sort of paralysing and ventilating. And then later that year, they had a 12-year-old girl in extremis with type 2 respiratory failure called polio, and she was actually unconscious and had a temperature and all sorts of stuff. And so Ibsen got a tracheostomy performed and couldn't ventilate the lungs. The lungs were completely stiff. And the sort of, I don't know, the fable goes that at that point, all the other sort of attending doctors, physicians, surgeons, and doctors in training walked away, often like an anaesthetist to a cardiac arrest situation. But everyone went away. And Ibsen then thought, well, hang on, I'll give us some thiopentone, I'll give us a bolus of thiopentone, and suddenly was able to ventilate the lungs. So that suggested there was some sort of bronchospasm there. And that girl survived. And so on the back of that, they then rolled this out, and all patients with polio were then given tracheostomies under local and manually ventilated with or without sedation as required. And on the back of that, they then very, very quickly built three 35-bedded units, and they had a team of about 1,500 medical students, retired people, coming to manually ventilate via waters bag, the CO2 absorber. So yeah, 35-bedded units times 3, it's just like Glenfield, you can imagine, can't you? And then they sort of designated that as an intensive care unit, and so ICU was kind of born as a specialty. In terms of what we do now, these are the sort of broad things, aren't we? So we do organ support, which it is not really done with the exception of NIPIA in any other part of the hospital. We admit patients for trials or treatments. We do that quite a bit. There's a whole load of uncertainty at the time of admission. But trials of therapy are quite a valid reason for admission. We also do palliative care, and so that applies particularly in patients either after admission or sometimes at the point of admission. So if somebody comes in with an unexpected catastrophic brain hemorrhage, the movement over the last 2 to 3 years has been to admit those patients initially for prognostication, but often at the back of your mind you're thinking of, you know, palliative care. Let's give the family some time to visit, to come to terms, etc., etc. So we do manage the family. Related to that, but not explicitly, is of course organ donation, which we facilitate in a variety of situations. But we also admit sometimes to help our colleagues out and help manage expectations. So it's a whole more holistic. I have to think of, and you know, because we admit all comers from all specialties, with the exception of children in this unit. It's a bit like general practice, really, because you're caring for the whole family, but without machines. Well, but with machines that go beep. That's about it, really. And the other thing that we are pretty multidisciplinary compared with, you know, okay, cancer and other general practice and things are very multidisciplinary, but we're more multidisciplinary, I would suggest, than, let me see, surgery or many aspects of acute medicine. That's changing, but I think we still are. And it was, oh, how did I get that? Hyde. Yeah. It was Dan Harvey in Nottingham, I don't know if you know him. He came up with this. He says intensive care is 2/3 acute physiology and pharmacology and pathophysiology, and it's 1/3 ethics. And I think that's kind of about right, actually. So a lot of you're well used to seeing physiology and diseases in intensive care and drugs, but the ethics is sort of about 1/3 of it. Certainly for the as you progress more senior now. Now, what does the Department of Health think ICU is? Well, this is quite a useful framework to consider. So it's about, and this is written in the Department of Health's framework for ICU, which is about 10 years old now. But they said we should avoid unnecessary suffering and premature death by treating reversible, my emphasis, illnesses for an appropriate period of time. So that brings in this idea of admitting for prognostication and family expectations. So that's a perfectly valid thing to do. But the purpose is to improve patients' outcomes in selected patients. So it's not everybody. And that brings into the concept of the capacity to benefit. And I'll come back to what that means later. And so it's quite explicitly, it says that the condition should be reversible and the patient shouldn't have significant comorbidity in order to be able to benefit, with the overall goal of stopping people dying. And you can do that even better by admitting them at the right time. Okay, any questions on that? No? So what don't we do? Answers, please. What don't we do? Or do we do everything?
Basically, we don't take the patients who are reversible.
Yeah.
Things going on, which we know that eventually.
Yeah. You've actually been very silent there with your mask on. Inscrutable.
we don't admit each and every patient.
Yeah.
That will be the first. And we don't do any harm.
Okay. Okay. So we don't admit all the sickest patients in the hospital. Many other, I think maybe junior doctors, nurses, other professionals, more senior doctors in some specialties maybe think we do this, but we don't. Okay? That's important. We can't reverse terminal decline. Okay? So if death is inevitable, we can't reverse it. We do sometimes admit full palliation, but that's a different thing. We shouldn't be prolonging life with no hope of recovery. And we don't leave important decisions to others. So hopefully you guys, having been here for a little bit, will realise that the consultants are around and involved in the decision making. We don't leave you alone on the wards at night to sort of decide life or death decisions, which does happen elsewhere, I think. Cardiopulmonary resuscitation is often quite linked with ICU, and the chap or the professor who more or less was the father of CPR, a chap called Peter Safar, who developed the first ICU in the US. He recognized the limitations of CPR, and this is a quote from him. And he said, CPR is for the person with a heart and brain too good to die. And I think it's worth sort of remembering that. I think maybe the whole of the hospital should remember that. And out in the community. It's kind of got a bit politicised, CPR treatment decisions and withdrawal of treatment, and families are involved. And it's also got much more bureaucratic with respect forms, which are now mandated for everybody. And in my view, bureaucratic and cause as many problems as they potentially solve. Because, and the reason I say that is because they are quite difficult and you have to involve the family, and it's yet more paperwork. People are actually were put off filling them in, so decisions were deferred without a discussion with the family, for example. So, how do you decide who should come to ICU? Well, there are a number of problems, which is why if you follow this as a career pathway, you have become an incredibly wise and well-paid person in due course. Even though you're wise at the moment, I realise you're not well paid. The problems are the patients. Patients are getting older, they've got more comorbidity and multiple comorbidities. That's the first thing which we all know. The second thing which you guys know is that there are increasing expectations from patients themselves, from families, relatives. I mean, thank goodness I don't work, well, we don't work in children's intensive care, because you just need to think of a few of the recent cases, the Charlie Gard run, for example, which got crowdfunding campaigns and all sorts of things, which were misguided and ridiculous, to be honest. This staff at Great Ormond Street were sort of bombarded by hecklers outside. Goodness. We also have new treatments with improved outcomes. So when I was your age, cancer was a death sentence, HIV was a death sentence, and so those groups of patients were often not admitted to ICU because of the concept of futility. But now treatments have improved and outcomes have completely changed, and that will continue to evolve over time. We're expensive and we are resource limited. That comes into the idea of distributive justice. What I neglected to say about distributive justice is not just treating all patients equally. It's the idea on a societal level that if you're giving an amount of a resource to some person or some group of people, it's then not available to others. So you have to spread things on a personal and a societal level. We are backed up by Department of Health and legal guidance, so the mental capacity is important to consider, and that introduced the idea of capacity itself. And that we should support individuals to make their own decisions where they have capacity, even if that decision is unwise. That might be declining treatment, for example, or actually going for treatment if the risks outweigh the benefits. And so what we then have to do as doctors is consider what is their best interest in terms of a sort of big holistic picture of the medical disease, the outcome, the expectations, and the burden of treatment. So that's what that would involve, both at the time, but also for the longer term outcome. So in a nutshell, if somebody's going to be treated and cured, but left in a situation that they would not be happy with, for example, lifelong dependency, then that isn't necessarily in their best interests. And we also introduced the cause protection, the INCAs, and the lasting power of attorney. So what are the sort of implications of the reasons it was brought in? It sort of followed on really from two cases, the Tony Bland case and the Leslie Burke case. Now, I don't know if you remember these, maybe not. Tony Bland was injured in the Hillsborough disaster of 1992, or maybe before that. I think maybe in 1990. But in essence, he had severe hypoxic brain injury because he was crushed in the stand and was in a persistent vegetative state, and he was fed. So he had a stomach tube, had a PEG inserted, and he was fed for over a year and showed no sign whatsoever of recovery. And the doctors and the family wanted to withdraw artificial nutrition and hydration to stop feeding, and they were told by the police and the coroner that if they did that, they would be on trial for possible murder. So they took it to court, and originally, the original decision was that, yeah, they weren't allowed to withdraw treatment. Subsequently went back to the Court of Appeal, who upheld the doctor's right to act in the patient's best interest, and that before the best interest concept has sort of been, I guess, promulgated. The second one was in about 2005, and this was a chap called Leslie Burke who had a spinocerebellar ataxia, a sort of progressive sort of MND type disorder that left him, at the time he was intellectually intact, but his body was failing and he was anticipated to deteriorate further and further. And again, he went to court to try and stop people feeding him. And again, the initial decision was no, he couldn't stop feeding him. It was then reconsidered under European legislation, European Court of Human Rights, was also brought to force doctors to go to court every time they wanted to withdraw any life support or withdraw anything. So for a while, we were all thinking, oh my goodness, we're going to be paralysed and by sort of this process, because you can imagine that can take months and months and months. Now, fortunately, that went to the Court of Appeal, and they judged that the doctors are under no obligation to provide treatment if they consider it's not in the patient's best interest. And that's a very important thing to be aware of. That's essentially the same thing. Just ignore that little alarm. It should get off. It's just telling me my blood sugar is a bit high. That's all. It's the excitement of giving the presentation. Or the 8 miles far down from lunch. Okay, so this then brings us back to the question of what benefits and maleficence. So we're supposed to assess the risks and harms of treatment acts in the patient's best interest, but more importantly, we're supposed to communicate that and discuss with the family and other care professionals. So what is capacity to benefit? Well, that's a bit more difficult. And again, that depends on medical condition, the burdens of treatment, the long and short term. And we also have to consider the consequences of ICU admission. Now, when I was a young medical student, I had no interest in anaesthetics. I don't think I ever went to the intensive care unit. I'm not sure it was a thing at that age. I became interested in intensive care really as a surgical medical house officer. And when I was a house officer, it just seemed to me that when there's really sick patients in the hospital, whenever the chips were down and you had nowhere else to go, you'd phone up ICU and they would look like that chap on the left. So they would turn up in a white horse. You can't believe it in the hospital, can you? But it really did. They would ride down and they would get the patient up on the stretcher and they'd take them away for about a week or so. And then they would deliver them back better. And I thought, wow, that's good, isn't it? I need to learn some of that. That will improve me as a doctor and a person. So I kind of got a bit interested there. And then, of course, I learned what it was all like. You come onto intensive care and you've got a sort of. Do you think the doctor there looks like a former England cricket captain?
Alistair Cook.
It's Alistair Cook, isn't it? So Alistair Cook was a part-time intensive care consultant. No, he wasn't. He's a farmer. But he's impossibly handsome, isn't he? But I thought, well, I would like to be like that. So that's really yeah. We've also got to remember the consequences of ICU admission. Some of those are the consequences of the disease. The box on the left, it's largely the autonomic nervous response, the stress response, if you like, cardiovascular, respiratory, GI, fluid and sodium retention. But there's things at the bottom that we do to people. We basically torture them with sedation or inadequate sedation, sleep disturbance, dreams, delirium, etc., etc. And then we stick them in a bed. They don't let them move, so they get pressure sores, they get DVTs, they get infections. In addition, and this is almost a separate talk actually, there are several things that we do to patients in intensive care. They're actually kind of harmful. Ventilation is bad for you. It has all sorts of cardiovascular effects as well as pneumonia and impaired coughing, etc., etc. The effects of drugs, they all have side effects, paralysing people. Well, we get paralysed, but certainly deep sedation produces problems with all sorts. We can kill people through sticking a vas cath into the carotid artery. If you've ever done that, not that I have, but it has occurred. Tracheostomies, I've seen people die from having percutaneous tracheostomies, so they've hit an artery. And then the effects of the environment. So there are all sorts of things, some related to disease, some related to what we do. Okay, so what factors determine outcome? Somebody come in, because I'm getting try math. What determines outcome?
The comorbidity also determine that.
Mm-hmm.
The physical status before admission. All depends the stay in the intensive care, how long you're staying in intensive care.
I'm sorry, they also develop the CT scan. Thank you.
Yeah, that's kind of circular argument. So it's not just the length per se, because the situations stay longer because the stay longer. Yeah. Okay, anything else?
This is process the treatment.
Yeah. Surveillance, yeah. And the response to treatment in the first 24 to 48 hours. And the age is also in there. Okay. So, yeah, I think you've got that. So it's whether the disease is reversible, whatever it is, functional status or frailty, and the physiological, especially cardiopulmonary, but also severity. So I think we've got most of these actually. And of course, if you put limitations, that kind of often does affect things. Right, the CFS. Who knows what the CFS stands for? That's the easiest question I'm going to give you this afternoon. Yes, it's devised by a chap called Rockwood. It's the Rockwood CFS. You've probably heard of that. And it was part of something called the Comprehensive Geriatric Assessment for use in a variety of scenarios, including primary care. That's the first important thing. It was never designed for deciding admission to hospital, limitations of treatment, admission to intensive care. What do we use it for in practice in 2023? Admission to hospital, admission to intensive care, limitations of treatment.
What are other problems with it?
Other problems? It's an easy one, isn't it? 0 to 9. Most people can count up to 9.
So it's very objective, very subjective. It depends on the person that's
It
performing
does.
the test.
It does. And who do you think most does this?
So usually it's the most junior person, or it's for pre-op clinics. It might be a nurse on the day, and you anyway perform wrongly, because usually it's assumed of the patient 2 weeks beforehand and not the actual person in front
So
of you.
which should it be?
It should be the patient that was beforehand. So what the patient was before they even came to us.
Yeah. That's what I'm going to take over. I think you could probably do this. Yeah, so that's important. It's done by the NAs probably, or maybe nurses. It is very subjective, and we don't usually, I don't think people do it on the basis of the person's underlying condition before the current illness, even if that was just sort of a month or so. So it's often done on how somebody is on the day, and that's not what it's used for. What's the difference between a 4 and a 5? Or a 5 and a 6? What's the difference between a 5 and a 6? So the answer to this is not on the slide. The answer is at the moment, a 6 means you don't get referred to ICU, and a 5 means you do. But that's nonsense, absolute nonsense. Just think about it. It's a more or less arbitrary subjective scale that's done incorrectly. So again, you should always just bear in mind, if somebody says a CFS, you really need to validate that with your own assessment of their functional capabilities. So it is useful, it's a score, everybody likes scores, but it does have limitations. So what about age? So aging is not good for you, really, generally. I think everything decreases by 1% from above the age of 30. That's the sort of rule of thumb, isn't it? Be it your GFR, be it your FRC, or VO2 max, or whatever you care to measure, it goes down. And that's just normal. That's part of normal physiology. But also at the same time, the older you are, the more likely you are to get diseases that can compound the deterioration of the function of whatever organ we're talking about. Old people get on more drugs, which then interacts, and you have these sort of nebulous things like deconditioning and frailty, which compound the whole process. So it's not good for you to get old. So if anybody can get me a cure for that one, I will be your best friend for a long time. So what happens with age? And there's the analogy I'm going to use. Who's an athletics fan? Anybody like athletics? Oh, you're useless. Anybody like cricket? Yeah, I thought we'd have a few. Yeah, okay. Well, there you go. But sorry, I've not got these for cricket because they don't exist. We'll look at some world records. So these are world records by age. So you've got men and women, red for men, blue for women. And this is the age standardized world records. So there's an absolute world record, and then there's a world record for age groups. Okay. And I'm going to show you several of these graphs, but they all illustrate the same sort of thing. And you can see, so Usain Bolt, he's got the 100 meters world record. That's 9.58 seconds, and that's pretty close. It's still about 10 seconds at the age of 30, and it's still it doesn't go. It's about 15 seconds for men at the age of 60, which is pretty remarkable, actually. I think I'd be on about 15 minutes, but there isn't really a big decrease in physiological or sprinting capacity. For sprinting capacity, read cardiovascular and respiratory peak performance and muscle performance. So it combines several things. But certainly after the age of about 80 in men and maybe 85 in women, it begins to decrease. Now, if we now look at the mile, so the mile is a bit more akin to intensive care because it involves aerobic, muscle, cardiovascular, respiratory components over a prolonged period of time. The world record for that is Al Garouj, and he set it when he was 25, 26. Usain Bolt's record was set when he was 23. Okay, so his peak was so the peak is actually in your 20s for these. And those lines start to deteriorate. So this is a bit more akin to the patients that we get. And so for men, it starts getting worse at about 65, for women at about 75. And if you look at something like the pole vault, okay, the pole vault involves agility, coordination, muscles, large amounts of explosive muscle strength. And that's a more sort of gradual deterioration over time. Again, because it's more about muscle strength, there's a bigger difference between the female and the male world records. I don't have the transgender figures, I'm afraid, but I'm not even going there. And for the javelin, again, that's more of a strength one. And so again, that's a sort of more gradual decline. Okay, the asterisks there are for the great Finnish javelin athletes. Jan. Oh, was it Czech? Anyway, Jan Zelezny. So, and that was, so this is quite an interesting one. So those are his best. He was the world record holder, but he also, and again, he set that at the age of about 30. But his best performance at the age of 35 and 40 also decreased. So his personal best for that season also decreased. That shows on an individual as well as a sort of group level. And then similarly for the marathon, again, things deteriorate from about 65 for men and from about 70, 75 for women. And again, the world aged marathon runner is the same chap. It's a chap called Ed Whitlock at 70, 75 and 80. Interesting, there is a 100-year-old marathon record for women. That's amazing, isn't it?
I thought it was more interesting as a pole vault of 95 years old. Oh, 90.
You're right, there's a 90, yeah. 90.
I think that's quite.
It's not very high though, it's only 6 feet.
Yeah, but how do you physically pole vault?
There's probably some sort of trampoline device, I would have thought. But yeah, it is. Yeah,
Cool.
it is probably one or two people.
It's quite high risk of
But again, so if you plot them reciprocal of the marathon, so this is more like again, there's a gradual decline, but it gets a lot worse after the age of sort of 75 or 80, whereas men decline more steeply than women at that point. And the reason I show this is because there's an analogy. You might have seen this sort of analogy before of this idea, the top red line there, it's a straight line for argument's sake, illustrates the sort of physiological decline that we all have with age. If you can see, now you can't see the colours on there, but in the top left, somebody has relatively minor illness, they'll lose physical capacity, but then they will recover. If they have a more major illness, they'll sort of follow this trajectory here, so the capacity reduces, it takes longer to recover, but eventually it will recover back to what would be their age predicted status. If they have a severe illness, an ICU type illness, then they may never recover full fitness that they should have done. And you can use those analogies for at different age. So sort of moderate or severe illness here produces a greater decrease in functional reserve. And if they make a good recovery, again, it's delayed. But if they get complications or get severe illness here, then they might have a sort of terminal decline. And so that's something that we have to kind of interpret in the context of patients presenting to us with a given illness at a given time. Now, I look back at ICU admissions to the MRI, and I did it over 12, 15-year period, stopped in 2015 because COVID had kind of screwed all these down anyway, for obvious reasons. And you can see the total number of admissions. It was about 1,400 in 2015, flat out at about 1,350 or so now. But that's across all age groups. Can you see the colours on here? You probably can't. Oh, can you? Okay. But yeah, so in the under 65s, which is the greater proportion, it's gone up. But the steepness of the total is greater than the steepness of the under 65s. And so what it means is that we're admitting proportionately more patients over the age of 65. And if you then look at mortality by age, again, on the y-axis is mortality and the x-axis is age, you can see that we've got fairly convincing evidence that mortality increases with age. But the interesting thing is if you look at the different cohorts over time, the bottom two, 2012 and 2015, so the mortality for those groups of patients has actually it's improved between over those time periods. Okay, so they're a lot lower than they were. And there's similar sort of picture for survival to hospital discharge. So in other words, we're admitting more elderly patients, but their particular mortality in terms of ICU mortality and hospital mortality is improving. Okay, so just to flick through a number of papers which will again kind of demonstrate this sort of concept. This is one paper aged over 80, admitted to medical intensive care units in France, and the mortality, well, 2 months survival at 2 months was 59%, so not great really, is it? 40% of them were dead. And the things that predicted survival were need for ventilation. So these are predicted death actually. Were fatal disease, need for ventilation, unconscious, or aged over 85 and shock. That was after admission to hospital, but the longer term mortality was associated with poor functional state and underlying fatal disease. This is another bigger study, multi-centre study from a French group. The groups 0, 1, 2 and 3 are analogous to level 0, 1, 2 or 3 in terms of organ support. So group 3 is a level 3 patient, group 2 is a level 2 patient, group 0 is somebody receiving essentially ward-based care. And again, you can see quite a marked relationship with age across all the age groups, whether patients were an HDU patient or an ICU patient. Again, this is another one. This was a trans-European study. Again, looking at mortality by age, and you can see both graphs. One is accepted or refused ICU admission. What's interesting here is that there's not an enormous difference in mortality at the younger age groups. So the mortality was sort of 14% in those that are either both admitted or refused ICU. But in the older age groups, the mortality was much higher in those who were refused. So in other words, the implication of that is that actually the elderly patient might have a greater capacity to benefit, but they're refused for other reasons. Another study looking, again, it was a study from Paris, looking at patients aged over 80. Most of whom were female, most of whom didn't have a lot of comorbidities. And there wasn't really a big difference in mortality or length of stay. Sorry, they did have a higher mortality, but it wasn't age per se, it was the other factors that was mentioned, severity, function, status, etc. And then this is a Canadian study of 24 ICUs over a 4-year period of 1,800 patients aged over 85. And importantly, if you look at the circles at the bottom, the So for overall, the mortality was the hospital mortality was 35% ICU mortality. But if you see among those who died more than 7 days later, there was a huge range. The median length of stay was 23 days to 3 weeks. And the range was 1 week to 629 days, which is quite remarkable. I don't suppose we wouldn't have an 80-year-old on here ventilated for almost 2 years. But the implication from this is that a stay in ICU is not necessarily a good thing. It's often a bad thing. Okay. Yeah, no, I'm going to flick through this. It's the same message. And the message is age is important predictor, but other factors are also important, and arguably more important, including frailty and the disease itself. Now, this is so this is about our end of life, a survey of end of life decisions amongst patients in intensive care and their families. And the most important things that they valued were trust and confidence in their treating doctors. They wanted to be involved in decisions. They didn't necessarily want to be kept alive. They also didn't want to be a burden. How many times have we heard that from work and our family? But also preparing for life's end and dignity is also important. And I think that's a lesson that we kind of need to bear in mind when we're next thinking of admitting or not admitting somebody to ICU. Okay. And here's one. This is another French study. So this was quite an interesting one. It was elderly patients. I think they went. So I think most of them were nursing home residents. They weren't in intensive care at the time, but they showed them a series of video scenarios of, this is what renal replacement therapy looks like. This is what NIV looks like. This is what life support, invasive ventilation looks like. And they asked them, would you want this? Would you want this to be provided? And the answers were the answers were quite interesting. So about a third of them would have refused NIV, almost half would refuse ventilation, and the majority would refuse renal replacement. That's kind of interesting, isn't it? Because renal replacement therapy we think is something that's more reversible than artificial ventilation. But the consequences are longer term if somebody needs dialysis, which you really don't want to be doing when you're in a nursing home. And they were also influenced by the quality of life. So that's where that comes from. The other problem is variability. So variability between doctors, between units. And here was this is a study, a sort of triage study. So it started off in the ED, and they looked. The ED physicians had to make an assessment on patients presenting, and they thought about 25% of their patients were eligible for ICU admission. So they referred them on to ICU. Of those, ICU agreed in about half the time. So that gives an overall percentage, half of a quarter, so it's 12% of patients were sort of admitted to ICU. There was, however, quite a disparity between referring clinicians and a disparity between referred clinicians, so between the ED consultants and the and you'll know that bears out our clinical practice, doesn't it? Our clinical experience. There are some that will refer evidence, there's some others that will refuse or decline more than others. But there is probably a problem there, isn't there? In terms of variability, you can't have a different doctor in either ED or ICU. Imagine you've got 2 hawks on one day and 2 doves on another day. That the outcome in terms of admissions could be completely different. And in terms of the mortality, again, it's a sort of similar sort of picture. Patients often, well, quite a high, about half of them were doing okay. Those that were admitted to ICU were doing okay, about half of them. But a third, only a third were sort of independent. Quite a few had a function deterioration. what was interesting in those patients where there was a culture of admitting more of the patients, that sort of inverse relationship there, the more patients that of aged 80 or above, I think it was, that the unit admitted, the better the outcome. So if you have a culture of saying no, can't do it, then you are less likely to have a good outcome. So to summarise the last few slides, the elderly often have treatment withdrawals decisions to make. Sometimes they have treatment withheld. We often admit for limited treatment, which is kind of you can question the logic of that really. If you're going to admit somebody, you could argue that you should admit them and do whatever it takes to find out whether they're going to respond or not. If you say, we're admitting them for this but not this, one of my bugbears is dose limits on vasopressor drugs. They can have up to 20 mils an hour of noradrenaline. Right. Has nobody heard of tachyphylaxis? So all the catecholamine inotrope-based vasopressors wear off after a while or become less effective because of tachyphylaxis. It's a purely physiological pharmacological effect. So setting a limit, so the likelihood is with a given degree of disease severity or vasoplegia, if you like, your noradrenaline dose is likely to need to go up over time. It's also highly nurse dependent, it's highly doctor dependent. We use too many vasopressors, not enough fluids, in my honest opinion. But you can see how ridiculously arbitrary that is. So I'm coming to the end now, you'll be pleased to know. There was a study here which is run out of Coventry, a chap called Chris Basford, if anybody's ever met him. And he's a medic ICU physician, was interested in the variability of decision making. So it was a sort of a qualitative type study, but we were observed for about a year. So we had a psychologist come in to observe the interactions at when a patient was referred to us, and she sort of listened in and made notes and then did some structured interviews afterwards to explore what had made us come to the decisions that we made. She wasn't interfering in decisions or anything like that, but she was just saying, well, why did you do that? Why didn't you do that? That sort of thing. And she found, not just here, it was multi-centered, that doctors often use this heuristics approach. So they kind of narrowed down the decisions to those parts of practice based on knowledge and experience, which you'll find that it happens to us all over time. You make decisions without necessarily going through all the steps. That's not necessarily a bad thing, because it allows you to speed up in your decision making, and allows the I suppose the benefits of clinical experience to weigh into whatever decision you make, rather than going back to square one. But it's can be a little bit simplistic, and as a consequence of that, we kind of forgot things like to involve the family as much as we should have, and made the patients, despite intending to. We didn't always. We kind of made them. And you can imagine, refer from ICU. Should we admit this patient? Yes, no. We don't say, oh, I'll just find out all the family members and have a conference to decide what they want to do. We don't really. You might ask the patient, somebody might, but very often not. So, and we were very bad at explicitly in those conversations that were had about balancing the risks and the burdens of treatment. So there are consequences of ICU admission, we said, death or survival, deterioration in the condition or complications, a prolonged recovery, and it is prolonged, it's months and months, with long-term consequences. And the other problem is prognostication and certainty. You can never be certain. Any risk scoring tool should not be used to arbitrate in a decision, because they're not individualized, be it surface score, be it clinical faculty score, be it an ASA grade, whatever it is, they shouldn't be used prospectively. And that's why the Possum score drives me crazy, because it was validated in one place at one time. But it's used to write, mortality 90% on an anaesthetic chart. Good anaesthetist, you can get that down. I would have thought. Good surgeon, you can get that down. Good hospital, you can get that down. And mostly things like that. So in terms of best interests, so the best interests have to consider both the outcome of the treatment, but also the benefits of that. Sorry, also the burdens of that treatment, and that should come into the decision making. We also need to consider who are the relevant parties. It's both the medics, it's the nurses, it's the carers, it's the GPs, it's the family, it's the nursing home, it's the patients, isn't it? It's all of those people, and we don't include all of them. We also should include the important outcomes for the patient. So if we say, well, we can get you better, but you'll be in a wheelchair for the rest of your life, that might be acceptable if somebody's close to a wheelchair and aged 80, but if they're aged 20, it might be completely different in both directions, actually. The idea of justice is about resources being distributed equally, and it involves the society and the individual, which might not, certainly we see that here. Many people the public will argue against certain treatments being available, but when it comes to them or their loved ones, then it will be a different matter. We also have this pandemic and the sort of moral injury and the sort of long-term burnout consequences that we're now kind of dealing with. So, time for the answers. What do you think we did? 63-year-old, we had this was a 5-4, 4-5 split, wasn't it? 4-5 in favour of the admits. So we've had more or less the ayes, the nice people on this side, and the others on this side. More or less. This is random with it. So did we admit, and what happened? We did admit, and she was discharged successfully to the ward to trial, and she died 6 weeks later. She had the benefit of the doubt sort of treatment. Nobody would really argue about that, I don't think. Or maybe the Hawks here would say, well, that's a waste of 3 days. Maybe.
It gives the family time as well, then.
Yeah.
As opposed to that.
Yeah. Little old lady. Now, this was a 9-0, wasn't it? Yeah. No way. Over my dead body is this woman coming to ICU. Do not admit. Aslan, you weren't here for this. Would you admit her? I've kind of given you a hint here. You wouldn't? Oh, so. We said we would admit her. We said, in fact, this was me. I said, well, if you're going to operate, you've got to give her the best chance. You can't operate and then time her his back and say, well, you can have some noradrenaline, and you have to find out. And you get some ventilating. We said we admit her, but she decided she didn't want to. She was 90. She'd kind of had enough. And then she got better. And at the time I decided, which was about, 5 months later, she was alive and well, alive, and no different when she was in before. So what does that illustrate? You don't always know what's going to happen, you don't always get it. But we involved the patient, she made that. Margaret. Sorry?
The patient, Margaret.
With the spinal injury?
No, hip replacement.
Oh, yeah. She's been discharged. Fantastic. Fantastic. Right, so this is the young man with sarcoma. Terrible prognosis. What would happen? Well, it's a difficult one. He was 24. So all the 4 of us who were on call that day got our heads together. We came to, it was in the end a unanimous decision, but we did have to kick it about for a while. And we didn't admit him on the basis that he already had life-limiting disease. And so he Didn't have it, so I don't know what happened to him. And 48-year-old lady, morbid diabetes, asthma. This was another. Was this a myth, or was it the other? It is just
This is
a
not our unit. Huh? I mean, this is like the standard.
It is.
Cover our unit.
Yeah.
Yeah. So you're going to admit her, and what happens? Yeah, happy story. So well done, guys. You got 1 out of 4 right in that. Well, we came to the right decision for her, and she actually got better. But on the face of it, this was during the COVID pandemic, and morbid obesity was a real problem because we couldn't program, as you'll remember. So we did admit, and she didn't get intubated, but she managed on an IV. So, talks about them ethics. I've just put this up because it's quite an interesting article in BT Education that we published about over 3 years ago now. I don't necessarily subscribe to all this, but it's from Dan Harvey, Dale Gardner in Nottingham, and they sort of go through the process of talking about what's in the best interest, and what the outcomes are important to them. So it's worth a read. And that's it. That's all I've got to say. So, questions?
So I had a question about case 3 with the palliative patient.
Yeah.
Why would we consider admitting palliative patients in the first place if we know they're palliative? Sounds a bit silly, but if we know they're palliative patients, like they're on a palliative pathway.
Okay. I don't know. Who can answer that?
Some conditions are still reversible though. So if they had like a pneumonia, for example, we could give them a chance to live longer. You know, they still have some quality of life. Like
Sometimes it's a bit more distressing to be in ICU and all sorts of things.
yeah, but it's their decision as well. I mean, you could talk to him, and wasn't his GCS was okay, wasn't it? Or his family, and he still had 6 months.
So yeah, so that's the answer. So you again, having said that some of the decisions in terms of limitations are slightly illogical, they are based to a degree on I suppose common sense. So the classic sort of case like that is somebody with a hematological malignancy who's got neutropenic sepsis, and it's sepsis, but her blood pressure is too low to be managed on the ward. Would we have to give her a central line noradrenaline to allow the antibiotics and other things to be taken? So yes, you would, even though they're on palliative chemotherapy and they might not be there for 6 months. So I would say yes in that case. And there might be important life events for them. You know, they might be expected to die in 6 months, but their daughter's wedding is in 3. And if you make a no decision now, that means they can't see the daughter's wedding as far as the daughter's wedding, or the son-in-law might not be still with his mother-in-law. But they're in life. It might be Christmas. It might be graduation. It might be all sorts of things that if you said to them, you're not going to get better. You're still going to die in 6 months, we think, or thereabouts. But if we do this and this and this, you might have a chance of surviving. But we might give you a pneumothorax, or we might cause a complication.
Yeah, exactly.
So you've sort of got, you do balance, but if you have to come, that comes into the patients and the families things and what's kind of important to them. And it's not, okay, we have to involve the patient in their best interest decision. And if we think, it is in their best interest to see the daughter get married or whatever it is, and they understand that their expectations are realistic, then that we might judge that is in their best interest. But if we disagree, then we're not obliged to provide treatment. Yeah, happy?
Thank you.
Thank you.
Thank you.
Thank you.